Well, thank you all for letting us be part of the Hope Conference. And unfortunately, as much as we miss seeing everyone together, I guess this is what we do these days. So anyway, so Dr. Singleton, I think everyone knows, is in Slidell, Louisiana, in the Louisiana Center for Advanced Medicine, and is, I think, well known in the community for her knowledge and expertise in the area of hemophilia and bleeding disorders. We very much appreciate her taking time today. I just, I know Dr. Singleton does a lot of speaking in some areas, but I really just said, I'd like you to do what you want to do with no boundaries or no agenda. So she sort of picked some hot topics in hemophilia. We're going to encourage folks to send chat in or questions, or if there's an area at the end when the questions that you would like to address for what you all have questions of. So Dr. Singleton, I'll turn it over to you and let you start your presentation.
Absolutely. Thank you so much for inviting me to be here today. And I have to say, I was super excited just to have an opportunity, again, sort of with the rails off, no boundaries, to have an opportunity to share some information and really, and more importantly, to allow you guys to ask questions about a few topics that I thought were kind of hot topics in hemophilia. And so I'll do my absolute best to answer any questions that you have. I am a director of a hemophilia treatment center, the Louisiana Center for Advanced Medicine and the Mississippi Center for Advanced Medicine. I am not, however, providing medical advice to any specific person today, but I think we can have a great conversation. And again, a little different because I need you to ask questions. So please, as we go along, type your questions into the chat. I'll try to keep my eye on the chat. If I'm missing a couple of things, please feel free, Mark, to let me know. Maybe if I'm missing questions, but I'll try to keep my eye on the questions. So let's kind of dive in and let's open the conversation. Here are my disclosures. Now, for those of you who have had an opportunity to be with me for some of what I refer to as our hemophilia conversations or lectures, I always like to start off with a reminder of what we're talking about, right? And all of my physician colleagues, all of my healthcare management colleagues, everyone on the HTC team, we all need to have a reminder of what actually happens with coagulation. And I think this is a fun way of thinking about it. So let's just look at this really quickly as a point of reference. So we're talking about hemophilia today. And as we talk about hemophilia today, what we're concentrating on, right, is the absence of factor VIII or the absence of factor IX. So what happens when it's there and what happens when it's not there and what happens when you need a bypassing agent? So this is an example of like an injury. So the center of that picture or illustration is like a laceration or injury of some sort, an injury to a blood vessel that may have occurred in a joint space. It could be anywhere. And so what happens is, you see where it says TF? Tissue factor combines with factor VII in its activated state, and it sort of rings the dinner bell for a little bit, a low level of thrombin generation. When you have that very low level of thrombin generation, your platelets, the cells in your bloodstream that help you stop blood, kind of kicks off the coagulation process. That thrombin dinner bell rings and your platelets jump into action and start to activate and kind of put out little feet, little pseudopods to bind to the area. Now, when those platelets activate, that is when you have factors that start to accumulate and then aggregate, and that kicks off the clotting process. Now, I always like to refer to factor VIII and factor IX as the big boys. When those two big boys come together, and you can see on the bottom of that platelet, see there, factor 8 activated complexes with factor 9 activated. You see that? When those two things come together, they then activate factor 10. I kind of refer to factor 10 as Big Daddy. Factor 10 is then activated and you have thrombin generation and a clot can form. So I wanted to re-explain that because again, I think that's a good point of reference, a great place for us to always start, because I want you to remember that factor 8 and factor 9 complex together and that thrombin has to be generated to have good clot formation. So you see that big yellow blob, thrombin generates, and then you have solidification and a final clot that will be in process. So keep that in mind, that when we want a clot, we ultimately want thrombin generation. And there are more ways than one to do that. And I'll explain some of that later kind of as we go along. Now, when you have an inhibitor, when we infuse factor 8 or we infuse factor 9, it doesn't have a chance to complex on the surface of that platelet because the antibody comes along and removes it from circulation almost immediately. So when there's an active high titer inhibitor present, a bypassing agent, when it's infused in, it skips over, I always call it the party on the surface of the platelet. It skips over that action, that complex that has to happen with factor 8 and factor 9 is not necessary. And it force activates factor 10 and you have thrombin generation that leads to a clot. So remember, ultimately we want thrombin generation and there's more than one way to do that. Typically, you can do that by infusing factor 8 or factor 9. If you have an inhibitor, you can use a bypassing agent, skipping over the need for that. Force activating factor 10, and you have thrombin generation. And then there are other ways I'm going to talk to you a little bit about in a second with some of those emerging therapies and with the way imosuzumab works as a therapy that has already emerged. So I always start with this. And it doesn't matter who I'm talking to, we always start with this. Okay, get your questions ready because we're gonna dive in and we're gonna talk about COVID. It's funny, I instinctively, you laugh, when I said COVID, I kind of looked for my mask. I looked around, looked around for my mask. Okay, let me just kind of get these facts out there. So, COVID is the disease process that is caused by SARS-CoV-2, right? It's the disease that's caused by coronavirus, SARS-CoV-2. The very first cases were known to cause a devastating pneumonia, and it was documented in Wuhan, China. I've been there several times. We also know that it is highly infectious. And what makes this particular virus so dangerous, the reason why we've been bamboozled, hoodwinked, and all of those things, is because it is highly infectious and the way it presents, meaning the symptoms that people can have, are all over the map. There's so many variables. So you could have it and be highly infectious. To give you an example, I have 3 children. One of my kids could have it and just kind of say, I'm not hungry today. Oh, I have a little headache, but that's it. Or nothing. But at the same time, they could be highly infectious. Sit down. Real life issues. My standard is here with me. So it has caused the worst public health crisis in a century, because of those broad spectrum symptoms and because it was so highly infectious. And I'm gonna throw in my opinion. And we didn't handle the communication early very well from a physician standpoint, right? From a scientist standpoint. I don't think that we communicated well. We do not have a vaccine for this and we have no highly effective therapies. So prevention is the key. And all of those things, period, the end. That's it. Those are the facts. Let me tell you a couple of other facts, and then I'll take a look at some questions. This is actually a little old. This is from last week. When I want to see numbers, I look at the Hopkins dashboard, and these are just facts. So as of last week, global cases, almost 45 million. In the US, we lead in a lot of things, but I don't want us to lead in terms of the number of cases, but we do. We also lead in terms of the number of global deaths. So as of last week, there were almost 1.2 million. And in the United States, we were approaching 230,000. And then when you look in the middle there, you can see the red dots, the red colors, those represent the number of cases. All right, okay. Now, I'm gonna go through this real quick and then I'm gonna look at questions. I said I was gonna look at questions, but check this out first. If you have COVID and you have a bleeding disorder, you have the same risk factors that you hear us talking about with everyone else in terms of having a very serious infection. This applies to people who are over the age of 60. This also applies to people who have hypertension, diabetes, cardiovascular disease, and immunosuppression, an immune system that is lower. Now, I want to clarify, that doesn't mean that there are not deaths or very severe infections in people in their 40s, 30s, 20s, and children. We do have deaths in those age groups. We do have severe illnesses in those age groups. It's just that there's a disproportionate number of people in those age groups. We also see a disproportionate number of people of color. So Black people, Latino people, Indigenous people who have very severe disease in comparison to their white counterparts. Does it mean that Caucasians are not leading in the number of deaths? No, it means that, yes. Yes. But in reference to the percentage of the population, those numbers are higher. So this is affecting us all across the board. Now, coagulation pathways are activated as a part of your immune response to this. So we are seeing patients that don't have known bleeding disorders or any other disorders that we know of that are suffering from strokes, heart attacks, and other clotting. Smaller clotting like DIC, thrombotic microangiopathies, bigger clots in lungs and other places. And it's very curious as to why that's happening in some of the younger adults. There's that DIC. It's associated with a very high mortality where you have a lot of coagulation factors that are being accumulated. If you are a patient with hemophilia, prophylaxis, whatever prophylaxis you're on, non-factor replacement therapy or factor replacement therapy absolutely should be continued during the crisis. Hands down, period, the end. And so patients with bleeding disorders of all severities, this is a statement that comes from the World Federation of Hemophilia Task Force. Patients with bleeding disorders of all severities, if they have COVID-19, whatever therapies are available should not be withheld. Ventilatory support, if you need extracorporeal, meaning outside of your body bypass support, if you need dialysis, nothing should be withheld. Those things should absolutely move forward. So no invasive management should be spared, but we have to make sure that we manage the hemophilia. Okay, I'm gonna go ahead and look at some of the questions. All right, let's see what we got here. Oh, I do see, I'm so sorry to hear that. I hear that there was a 16-year-old boy who died in Missouri 2 days ago from COVID. Again, this affects all of us, everyone, right? It doesn't matter the age. Let's see. All right. I'm looking, I see tons of good mornings. Do you guys have any questions about COVID? Any burning questions? There's no question that's silly. You can go ahead and type it in. And I do see a comment, someone who had COVID pneumonia in April. And there was something called neutropenia, where you have a low white blood cell count. That absolutely happens and can happen as a response to any infection, viral infections, bacterial infections. Your counts can go down, including white cell counts like neutrophils, typically in response to the infection. It's almost as if they're being used or activated at the time. And so when we go to count them, they're not available for counting. Okay, here's a question. Oh yes, I see a comment that they gave heparin because of the risk of blood clots. Absolutely. So heparin is a part of the protocol for severe COVID infections. And that too is not typically and should not be withheld from a patient if you have hemophilia. However, what does happen when you have hemophilia and you need to be anticoagulated for whatever reason, the thought is that we try to make you hemostatically, meaning we maintain your prophylaxis, we maintain your factor levels, we maintain whatever it is you're on, maybe even supplement if you're on non-factor replacement therapy. We need to make sure that factor levels are within a normal range so that we can appropriately anticoagulate, because those systems, especially in the face of an infection, can operate completely independently. And I know it probably sounds a little crazy, but your clotting system has many different on and off switches, and we can't turn them all off, just as we can't turn them all on. That is operating independently over here, and infections often activate your clotting system. Meanwhile, if you have a bleeding disorder over here, you may have a deficiency of a coagulation factor or a protein if it's von Willebrand's. So we need to make sure that that is managed and handled and replaced over here, while we do everything we can on this side, maintaining that balance to try to prevent clotting elsewhere. So again, I know it seems kind of counterintuitive, but yes, if you have a bleeding disorder, can you have DIC? Can you have thrombotic microangiopathy? Can you have regular clots? In response to an infection, absolutely, absolutely you can. So patients who have hemophilia or the bleeding disorders, if you have a severe infection, you may absolutely receive anticoagulation to try to prevent some of the life-threatening complications that can occur with COVID. Absolutely. It is important, I think you could imagine, that if you have COVID and have a serious infection with COVID, if you're facing the need of anticoagulation, a hematologist who treats patients with bleeding disorders absolutely needs to be provide a consultation or be a consultant with that ICU team to make sure that you have proper care. Okay. All right, hang on. I'm trying to get back to the question. Okay, let's see. How does co-infection with HIV affect COVID? So co-infection with HIV is not known to have any impact or effect if you have COVID and HIV present simultaneously. There's no increased risk of infection that we know of. There's also no increased risk of severe complications. However, if you have HIV and by definition, you are significantly immunosuppressed or have AIDS, that means that you have a CD4 count that is less than 500. Now that is a risk factor. That falls into that immunocompromised category. And there are various ways the person can be immunocompromised. You can be immunocompromised by, again, having HIV and a CD4 count less than 500. AIDS by definition. You can have an inherited immunodeficiency. You can have an acquired immunodeficiency because of medications that you're on. If you're on high dose steroids for a long period of time, if you're on other immunosuppressants, if you're a cancer patient and have been on chemotherapy, those are ways that you can have an acquired immunodeficiency. And yes, the risk will be higher in terms of your response or severe disease in that setting. Can you get COVID more than once? Absolutely, you can. Let me explain why. You can have COVID more than once because, number one, we don't know with this particular virus what immune status, meaning how high your antibodies need to be and sustained in order to fight a second infection. We don't know that information. We don't know once you've had COVID, how long your immunity lasts. And we don't know what that level needs to be if you're re-exposed a second time. We do not know the answer to that question. Secondly, viruses mutate. I know that you guys understand that, and I know that you've heard of that before. Meaning, a virus can infect 10 people and then get a little smart, develop a different characteristic, add on another little arm, add on another little tail, and now it can elude or change a receptor, and then it can elude therapy or sort of sneak in and hide from the antibodies that you've made. A good way of thinking about that is every year for the past at least 20 years, I've received the flu shot every year. Okay, except once. And that one year I got the flu and I negotiated with God and prayed and said, Lord, if you let me live, I'll never miss my flu shot again. For real. Okay. So every year I have a flu shot. And why do I have a flu shot every single year? Because there are different strains, because that same influenza B virus can mutate or change. And typically with the CDC and our European counterparts, they have a surveillance system where they're aware of some of the new variants, the more common variants, and they tailor the vaccine to those variants every year. So I had the flu actually twice in my life. Once when I was in college, I didn't have a flu shot at all then. And then a second time when I was a young, doctor in charge, I was a young attending when I missed my flu shot that one time. So the example that I had it twice, although I was vaccinated many times in between, kind of explains how. And we do know, drop a couple facts on you, we do know that coronavirus SARS-2, scientists have picked up a couple of mutations in Europe. We don't know the significance of those mutations yet. We don't know. But yes, that's how you can have it more than once. Does the comorbidity of hemophilia increase the risk of occurrence or death? No. Having hemophilia alone, as far as we know, we have seen no cases that you have an increased risk of acquiring the infection or being infected. We also do not see an increased risk of severe disease or death just because you have hemophilia. However, if you have hemophilia and you are older, you have other comorbidities, other conditions, diabetes, high blood pressure, yes, asthma. So other things can predispose you to a more severe form of the disease if you have hemophilia. Okay. Does COVID affect hemophilia or vice versa? I think I answered that. Teenage boy now always taking factor and immune system is poor. If give COVID more apt to bleed more. No, you're not. No, there's no increased risk of bleeding more. But if you have a compromised immune system, your infection with COVID could be more severe if you have a compromised immune system. And I want to throw this in. I have a lot of conversations, detailed conversations with my patients, the patients that I see. And I think that's a very sacred relationship. I hope that if my patients have questions about their health, or if my patients have questions about COVID or coronavirus or how it could impact them or their families, I think that they trust me enough. They would come to me with their questions for clarification in terms of how to stay safe. I think that you too have that same opportunity with your HTC. Talk to your hematologist, talk to your team, get clarification specifically related to you and your family as to how you could move forward and how to move safely within this environment, how to protect yourself, right? How and when to wear your masks, how to keep your hands clean. And I'm sorry, I just have to take a second to add this in, and I'll go back to some questions. So I am a physician, but even prior to the whole COVID crisis, I will say that I'm also a self-proclaimed germaphobe. Yes, believe it or not, I'm a little bit of a germaphobe. How can you be a doctor and be a germaphobe? Actually, they go quite well together, because I need to make sure that I do not transmit anything from patient to patient. When I see one patient who's incredibly sick, I also need to make sure that I don't catch anything from a patient. I need to make sure that I don't give anything that I have to a patient. So that germaphobe thing that I have going on, oh, it works perfectly. Always keeping my hands clean, always been, and because of that, they're so dry, but that's okay. I mean, I work it out, but keeping my hands clean constantly, because I too accidentally do things like this, touch my face, touch my eyes, rub my nose. I try never to put anything in my mouth or touch my mouth without making sure my hands are clean. If I think I'm sick, if I even think I'm sick, I'm gonna wear a mask when I come in to talk to you. And I have done that for 20 plus years. If I'm seeing very sick patients, if I think someone has an infectious disease, I will see them last. When I'm in the hospital setting anyway, not first, right? Because when I know that, but I always act as if something is going on. So please make sure that you do everything you can to protect yourself in the middle of this pandemic. Because we want to have some freedoms. We want to go out and kind of do things, but we have to do it with some modifications. Okay. And if you have any thoughts or questions about masks, share those too, so we can have a dialogue about that. All right, look, let's see. This is a comment and a question. My grandson gets pneumonia every winter season. Will that make him more susceptible to COVID this year? Okay, so typically when you're describing someone who has pneumonia on a schedule, that is related to seasonal allergies and a reactive airway, typically. When you have seasonal allergies and that reactive airway, that predisposes you and sets you up for pneumonia, a viral pneumonia, a bacterial pneumonia. That needs to be controlled. You need to have a conversation with your doctors about that recurring pneumonia so that you understand exactly why that's happening and what you can do to control or prevent that. Because if there's an underlying condition, reactive airway disease, asthma, seasonal allergies, if there's whatever is causing that, that needs to be in check. If it's something as simple as using antihistamines and steroids or breathing treatments or allergy shots, that needs to be addressed so that you can start to decrease the impact that either COVID or something like COVID could have. Okay, I hope that makes sense. Yeah. Somebody's commenting they've had a flu shot every year since 91, no spleen. Yeah, I have a flu shot every year. and my family, I have to get everybody vaccinated this weekend. I keep putting it off, and it's going to happen this weekend. I had my flu shot, but I have to vaccinate all of them. COVID-19 respiratory impacts. Can hemophiliacs incur lung damage or become a lung hauler? I don't really know what that means, but yes, you can have lung damage and other things that can occur if you have a severe infection with COVID-19, just like anyone else, but the risk is not increased just because you have hemophilia. Absolutely. You guys tell me, what does that mean? I always like to know what things mean. So I know, lots of other terms, like when people would say free bleeder, I had to marry that with my non-doctor mind and my doctor mind many years ago. I understand what that means. So tell me what that means, a lung hauler. I want to know what that means. But going back, severe respiratory impacts, no, not just because you have hemophilia. Yeah, I do take COVID very seriously. I'm a doctor, that's what I do. Is long-term mask wearing a higher risk, like some myths suggest? So I'll give you the Singleton rationale, like behind that. I'm not a surgeon, but I do procedures, and I have spent a lot of time in training in operating rooms. And I treat bone marrow transplant patients, and I have to wear masks. And so I have had periods for 25 years where I have had to wear masks for many, many hours, off and on throughout the day for 25 years. I've never heard of any evidence-based study or report that says that there's a negative impact on the healthcare population, doctors, nurses, surgeons, because we wear masks for extended periods of time. There are surgeries that take 24 hours to complete. There are surgeries that take 44 hours to complete, 14-hour surgeries, 12-hour surgeries, every day. Some doctors are operating 5 days a week, masked up, gowned up, lights on, and the entire surgical team all day, every day for many, many years. And even before we had masks that are as high in terms of quality as we have now, what the masks were like 30 years ago, we still wore masks, still wore them under those conditions. And I know of no evidence-based study that says that we have significant health impacts because we wear masks. So I would say the answer to that is probably no. Now I'm all about education and the Socratic theory, and I really believe in that quote from Henry David Thoreau that education is the journey, not the destination, from cocksure ignorance to thoughtful uncertainty. So I think that when you're truly wise, you always have that thoughtful uncertainty. So I will again say, to my knowledge, I don't know of anything from an evidence-based standpoint that would suggest that you will have damage from wearing a mask. Now, let me share my common sense perspective on that. People die from COVID, but I'm not going to die from wearing a mask. And that was Tammy talking. That wasn't Dr. Singleton. Okay. I have reactive airway from COVID. Does that make me more at risk for pneumonia again? It's possible. It's possible. And when I say that it's possible because when there's like some injury that's there. So you always want to make sure that you have a detailed discussion with your doctor about that to make sure that you understand whatever your risk factors are, because this is possible. And maybe why you were set up for that in the first place as well, too. Oh, let's see, lung hauler. Lung hauler is someone that takes a long time to heal with lots of side effects. Oh, I'm so glad you shared that with me. I needed to know that. Got it. Okay, I've never heard of that. Okay. Didn't clear up until September, short of breath, headache. Okay, got it. Thank y'all, I appreciate it. Okay, all right. I think that we beat COVID to death. We have a few more minutes. See, I knew that we would get carried away and could talk about something, but I thought that that was a meaningful conversation. How about you? So I'm gonna close that out and just spend a couple of minutes with this and fire away any questions if you have them, because there's just a couple things I want to talk about real quick, and I think I can get through it. Okay, remember, I just told you, some of you came in late and might have missed it, but I started out explaining how coagulation happens, right? Remember, thrombin generation is the ultimate goal, and there's more than one way to get that done. So with some of the newer therapies, I'm going to talk about some of this real quick. With some of the newer therapies, the focus is on thrombin generation, not just factor replacement. So when you replace factor, factor helps to generate thrombin. So the thought is, how can you generate thrombin in other ways? So the first way is a substitution therapy. That's what imosuzumab is. Imosuzumab is a monoclonal bispecific antibody. In medical science, you know a lot about antibodies. It kind of acts as a substitute or a mimetic for factor VIII. Look, real quick, on the left, you have what factor VIII does. You see factor VIII in its activated state there, binding to factor IX activated and binding to factor 10, boom, thrombin generation. You see that? Factor 10 activated, thrombin generation. Well, when you have the presence of imosuzumab, when you have a deficiency in factor VIII, imosuzumab will bind to activated factor IX, bind to factor 10, allow factor 10 to activate, and thrombin generation. See, like a substitute. Again, the end goal is thrombin generation. Now, there's something called rebalancing therapy. So there are a few things in clinical trial. I'm just going to tell you about the two that are kind of hot right now. They're in phase 3 clinical trials. Fitusiran keeps the switch off. It keeps the off switch off. Okay. I can't stand the coagulation cascade when it's presented with those Roman numerals. I hate it, but just bear with me for a second because this is like the best example I could find. So see, when you have factor 8 and factor 9, you see that on the left, and it's going through the cascade and going to generate thrombin that way. Well, just like your body has coagulation factors, your body has anticoagulation factors. So like your body's natural anticoagulants, right? Natural anticoagulant. So something called antithrombin will kind of put the brakes on, kind of give the hand to factor 10. So that factor 10 can't cause thrombin generation. You see what I mean? It's an anti-thrombin. It stops the generation of thrombin. Well, we know that there are children and babies that are born with antithrombin deficiency. Yep, I take care of those too. So congenital antithrombin deficiency. In babies that are born with congenital antithrombin deficiency, what do? They clot. So scientists said, that might be a good idea. What if we turn that off switch off? What if we take away some of your natural anticoagulant, the antithrombin 3, and allow thrombin to generate so you can have clot formation? What would happen? Well, that's what happens with fitusiran. So on the right there in that circle, you see fitusiran, and it's binding to the receptor, going in, and it's something called a siRNA, a small interfering RNA. It's like a little annoying little character that stops the production of protein. That's a way to think about it. It stops the production of antithrombin 3. So that's what fitusiran does. It keeps the off switch off. The next one is called anti-TIFP inhibitor. I love this little cartoon. So it's an anti-tissue factor pathway inhibitor. So the tissue factor pathway inhibitor, the little black things at the top, you see that? That will come along and interfere with activated factor 10 and activated factor 7. It'll clamp down on that whole process. So it doesn't allow Big Daddy, factor 10, to be activated, so you have thrombin generation. So that's the natural off switch. Well, what if we have an antibody that blocks or turns off the natural off switch? That is what an anti-TIFP inhibitor does. And it will do it for anybody, factor 9 deficiency, factor 8 deficiency. It can do it with an inhibitor because it's turning off. The off switch is over here. So it doesn't care what's happening with factor 10, factor 9, factor 8, anything over here. It's working over here on your body's natural anticoagulants. Okay. And then here's a list of some of those that are currently in clinical trial. You see status, phase 3, the Bayer product closed last year, but there's a Pfizer product that's a TIFP product. There's a Novo product that's a TIFP product, that Consuzumab. Fitusiran, I described to you, that's Alnylam, and then Emicizumab is already FDA approved. Okay, I literally have 2 minutes, barely, so let me see. Yeah, if somebody in your household has COVID, you could turn on the AC. It would still be a nice idea to get a HEPA filter, you know, just for your house in general. Just keep them in the room and wear a mask, and they need to be quarantined. But you can't sit in the heat and with no, it's worse to have everybody sitting there with no circulation. So you have to have circulation. Okay, listen, if you guys have any questions, we'll have to do this again another time. This is me rails off, just describing and talking and answering your questions, which I think is so fun. I wish I could just pull up a stool and just, you know, talk and answer questions maybe the next time we're in person. Okay. All right. And I did it. It's 11:45. And I did have one more slide. Okay, let me tell you this quick, 30 seconds. Gene therapy. Gene therapy is in clinical trial. Nothing is approved for factor 8 or factor 9. It's called gene transfer. It's a single one-time IV infusion. It uses an adenoviral vector, not a live virus, just the shell of a virus with functional DNA that we've created in the laboratory for factor 8 or factor 9 to make it. We infuse it. In theory, it finds itself to the liver, or it goes to the liver cell. And that's what you see there on the right, like that liver cell. It goes in the liver cell into the nucleus and makes a circular episome, a little circle of DNA. It doesn't integrate into your DNA. And then it makes the functional protein. That's how it works. Talk about that another time. Okay. Thanks for having me.
Thank you, Dr. Singleton.
Yeah, thank you, Dr. Singleton. We so appreciate you, as always, jumping in and participating with us. Thank you, First Choice. Mark, do you have any closing words you'd like to share?
I think just to go on kind of today's topic of the COVID thing of, I know we're all wore out with it and trying to be safe and all of that, but as we all know, the numbers are getting worse, most places, not better. So be very, very cautious, be very, very safe. Let's all live again to see each other.